Hey everyone, and welcome. Today, we are diving deep into what is easily one of the most detailed areas in all of medical coding, Chapter 15 of ICD-10-CM. We're going to break down the essential guidelines for coding pregnancy, childbirth, and that postpartum period, and really turn all that complexity into clarity.
So here's our game plan. We're essentially going to follow the patient's entire journey, right from the beginning. We'll start with the absolute basic rules, then move through the pregnancy, into labor and delivery, cover the postpartum period, and then we'll even tackle the specific procedures and other related encounters. Trust me, following this story makes all these rules just click. Okay, let's jump right in with the absolute basics. Think of these as the foundational principles that govern every single obstetrics code you'll ever assign. You really can't code without them, so getting these right from the get-go is totally non-negotiable. First up, let's get a key term out of the way, the puerperium. This is the official coding window for everything postpartum. It starts the second that delivery is complete, and it lasts for exactly 6 weeks, or 42 days. You've got to keep this time frame in mind because it's critical for picking the right codes for any complications that pop up after the birth. Now, for the real rules of the road for Chapter 15. First, and this is the golden rule, these codes always have sequencing priority. That means they get listed before codes from any other chapter, period. Second, these are for the mother's record only, never, ever the newborns. And finally, always keep an eye on that final character. It often tells you the trimester, which is an absolutely crucial detail for accuracy. All right, with those basics under our belt, let's see them in action during the pregnancy journey itself. This part is all about coding everything from that first, totally normal prenatal visit to the much more complex management of a high-risk pregnancy. Okay, this is a huge one. This is a fork in the road you have to get right every time. For a completely routine, no complications pregnancy visit, you're going to use a Z34 code. Simple. But the moment a risk factor is documented, we're talking advanced maternal age, a history of preterm labor, anything like that, you immediately switch over to category 009. And here's the key. These two categories should never, ever be used together. And just when you thought it couldn't get more specific, it does, especially with multiple babies. When you have a complication with twins or triplets, it's not enough to just code the problem. You have to use a seventh character to pinpoint exactly which fetus is affected. Fetus 1, fetus 2, and so on. It's absolutely vital for accurate clinical documentation. And now we get to the main event, coding for labor and delivery. This is really where the rubber meets the road. It's where you'll find some of the most complex coding challenges, and where precision means everything. So let me ask you this to get us started. With everything that can happen during childbirth, what does it actually take for a delivery to be considered normal from a coding standpoint? While the answer might surprise you, it's way stricter than you probably think. You see, to use code 080 for a normal, uncomplicated delivery, you have to check every single one of these boxes. It has to be a single baby, live-born. The presentation has to be cephalic, head down. There can be absolutely no instruments, no episiotomy, and no complications whatsoever. If there was a pre-existing issue, it has to be totally resolved. Any active problem, and 080 is off the table. Let's really hammer this home. Any little deviation from that perfect scenario means you can't use OASIA. So a breech presentation? Nope, not a normal delivery. The doctor used forceps or vacuum? Definitely not a normal delivery. Even an episiotomy, which is pretty common, is considered a procedure, so no OASIA. It just shows you how incredibly narrow that uncomplicated definition truly is. Now let's talk about something on the other end of the spectrum, a common complication called obstructed labor. This is one of those classic issues that immediately throws normal right out the window. It's exactly what it sounds like. The baby is physically blocked, usually because of its position in the birth canal. And here you can see exactly what we're talking about. Look at these different fetal positions that can cause that blockage. A breech presentation or a transverse lie, where the baby is completely sideways. These are the kinds of specific clinical scenarios that point you directly to an obstructed labor code, taking you miles away from that simple 080. All right, the baby is here, but our coding work is definitely not over, not by a long shot. Now we're moving into that critical 6-week period we talked about, the puerperium, where a whole new list of potential complications can show up.
This postpartum period has its own whole minefield of potential issues, and each one has its own specific codes. We're talking about really serious things like postpartum hemorrhage, heart conditions like peripartum cardiomyopathy, or dangerous infections like puerperal sepsis. Nailing these codes is so important because they represent serious risks to the mother's health. So, what happens if a complication from the pregnancy causes a problem months or even years down the road? That is exactly what code 094 for sequelae is for. This isn't for an active problem happening right after birth. No, this is for coding the treatment of a long-term consequence, like, say, needing surgery to fix a prolapse 2 years after a really traumatic delivery. So far, we've been all about the diagnoses with ICD-10-CM. Now it's time to shift gears and look at the procedures with ICD-10-PCS. This is where we code what was actually done to help deliver the baby. Let's break down the structure of these 7-character PCS codes. Think of it like building with Legos. Every single character has a specific job. The first one tells you it's obstetrics. The ones that follow tell you the body system, the root operation, which is just a fancy way of saying what was done, the approach, and so on. It's a really logical system for defining exactly what happened. Okay, everyone, lean in for this one, because this is a huge source of errors. It's about the language used for root operations. You'd think a C-section would be coded as a delivery, right? It makes sense. But in PCS, delivery is only for manually assisting the baby out. A C-section, or using forceps or a vacuum, that's all coded to the root operation extraction. Getting that distinction right is absolutely vital. Perennial lacerations are super common, and coding them correctly just requires attention to detail. It's a clear progression. First degree is just superficial. Second degree gets into the muscle. Third degree involves the anal sphincter, and a fourth degree tear goes all the way through into the rectal mucosa. The key thing to remember is that the diagnosis code you assign has to match the highest degree of tear that was documented. And for our final section, we're going to look at those related encounters that use Z codes. Think of these as the codes that fill in the rest of the patient's story. They're not for a current illness or injury, but they're still critical for capturing the whole picture of patient care. Take contraceptive management, for instance. It's a perfect example. You can see there are super specific codes for pretty much everything, from the initial prescription for birth control pills to inserting an IUD or even a sterilization procedure. These codes let us accurately track all these important healthcare services. And on the flip side of that coin, we have codes for procreative management. This category covers all kinds of services, from fertility testing and counseling all the way to encounters for an IVF cycle. It just goes to show you the incredible breadth of patient care you can capture with these Z codes. Wow, we have covered a ton of detail today, from the simplest visits to the most complex deliveries and their long-term effects. So I'll just leave you with this final thought. Now that you've seen all the layers of specificity required, what's the most complex, wild obstetric coding scenario you can piece together in your head? It really makes you appreciate the detailed story that accurate coding can tell. Thanks so much for joining me.